Testing 1-1 presenter. Testing 1-2 Zenarosa. Testing 1-3 Dr. Webb. Testing 1-4 DeBose. Testing 1-5 DT. Testing 1-5 DT. Testing Zimmerman 2-1. Testing Reverend Emerson 2-2.
Somebody'd like to make them? You got them both? You got them both? Okay. Any discussion? All in favor, please say aye. Those opposed, same sign. Okay, Zim, for you and Amanda, we get these policies because they're joint commission sort of necessary, and they fall under the medical staff, nursing, so they come to this committee. That's why there's the Reverend, how are you, sir? The first one is the Tarrant County Hospital District Board of Managers Resolution of Commitment to Patient Blood Management. Hey there.
Good afternoon. I'm coming this afternoon to request your approval of a resolution for the hospital district to commit to a patient blood management program here at JPS. And this would be going through the Joint Commission as a certification. There's only 7 hospitals right now in the U.S. That have this certification, and there's none in Texas. But what it is it's a commitment from the organization to really look at and study blood conservation, to look at the safety and ordering, administration, transfusion, guidelines, those type things around the administration of blood and blood products. So I'm coming to ask your permission for us to proceed in doing that.
So what is the certification? What is it?
It's in patient blood management.
Blood management. Okay. Any questions for Wanda? Please.
Carter Blood Bank. Absolutely. They're actually have a housed here in our facility. So.
Okay. Cool. Thank you.
Anything else for Wanda? Somebody might like to make a motion that we approve this.
Second.
Second from Amanda. Discussion. All in favor, please say aye. Those opposed, same sign.
Thank you. Next, I have just a policy for your review, or it's actually a plan. It's our utilization review and care management plan, and this is a CMS requirement. We've had this plan in place for many years. It's just up for review, and basically it's formatting changes, a little bit of verbiage, and the addition of the line in here to reference the 2 midnight rule. And those are the only
That's
changes.
one of the things I had underlined that folks may not completely understand. Could you explain the 2 midnight rule, please?
I'll do my best. It's very complicated. It sounds easy, but it's not. It's just that once a patient has been in the hospital for more than 2 midnights, then they either need to be discharged or they need to convert to an inpatient status if they've been here under observation status during that time. But once they pass that 2 midnights, then they either need to change status one way or the other.
Okay. Everybody okay with that? Okay. I found one little clerical error for you.
Okay.
At the bottom of page 737, just number 4 should, I think, defines processes, just like the.
Oh, I see that. Okay. Great catch.
There was one I was going to try and get you before the meeting. But I think the main thing for us, even other approving this, but there are responsibilities for the governing board that are listed here on page 10 out of 37 that we will be coming back to visit. If it's okay. Dorothy? Is there a second? Reverend Ralph Waldo? Second. Discussion? All in favor, please say aye. Those opposed, same sign. Okay. Is that it for you, Wanda?
Thank you, Wanda.
Okay. Rob, I think,
Yes.
does everybody know Dr. Stevenson? Okay.
So I think this is also a renewal of a policy, and I'm going to feel a little bit with my drawers down a little bit on this, because actually I wasn't completely aware of this one on the agenda, so my apologies. So please forgive me.
That's okay.
Where does this one start? Do you know which page this starts, Sean? I'm sorry.
It's okay. It's right after the utilization management. It's a very short,
Yes, very short.
in my book, it's 21 out of
21, there we go, I'm sorry. So, this policy of the Trent County Hospital District states that patients and their families or representatives are informed through the proper chain of command about unexpected outcomes of care, including unanticipated outcomes or medical errors. This policy will apply to all district employees and members of the medical staff. So pretty straightforward, but it's basically an intention to say that when something untoward happens to somebody, that we will not conceal this information from the patient, but we'll be upfront and open and let them know about the things that are happening to their to either themselves or to their family members.
And we've had this policy in place.
Yes.
So the only difference is there was a minor correction to this
Yeah.
over time. These policies are going to have word changes, and any change, including a comma, has to come through this governing board for its approval. So this isn't a new policy. This isn't anything that's revolutionary to us. This is just a minor change, and it's got to go through you all to do
Yeah.
that. So that's all there is to this.
And Sam and Amanda, at this committee, we only approve the policies. We don't get into the
Actual
execution
Right.
of how that all works. That's, yeah, the procedure part is highlighted. Okay.
Okay.
Could I make a statement about, even though they have it on our board portal that we can pull up, you can't really pull it up, you have to have a tech number. Okay?
You, tell me again, you have to have a,
And when you click on the procedure, it comes up and it'll ask for the tech password. Policy tech, and it user and their password. So,
I just said, hell,
okay.
I don't, I just thought I'd mention that so y'all could work on that in
Sure.
case I wanted to look at a procedure.
Sean's got it.
I have that issue, and so it's in the reference materials, but it doesn't go to the actual procedure, right? It just goes to the, yeah. That's all.
Yeah.
Okay, well, we will make sure, and we'll go through policy tech, and I'll ask David to take a look and see what makes it easier for you guys to pull up the procedures in the policy.
Okay.
We can do that. Thank you, Dorothy.
Somebody like to make a motion, we approve it?
Second.
Discussion, all in favor, please say aye. Those opposed, same sign. Kenny's coming up, Kenny Carr.
Everyone. Much like Wanda and Dr. Stevenson, I have a couple of policies that are up for renewal. The first one is the environmental surveillance policy. It's to conduct regular environmental tours of all the areas in the organization and determine whether the current activities are used to manage the environment of care, or EOC, are effective to identify and correct any discernible hazards that may exist to our patients, our families, and visitors. And so this policy, there was a couple of words that were changed, wordsmithing, but overall, nothing substantial has changed.
Okay.
Any questions for Kenny? Entertain a motion to approve.
Second.
Second by Dorothy. You got any discussion? Any questions for Kenny? All in favor, please say aye.
Aye.
Those opposed, same sign. Okay?
Okay.
Next one is in regards to radiation safety. This policy statement is to establish and strictly adhere to the safety procedures and to maintain the records of compliance and control in accordance with the requirements of the Texas Department of State and Health Services Radiation Control Program, and is established standards and procedures for radiation safety to meet all the legal requirements. This policy statement had a couple of wordsmithing and no significant other changes were made.
Questions, comments for Kenny?
Move approval.
Second by Dr., Mr. Newman. Yeah.
All right.
Discussion, all in favor, please say aye.
Aye.
Same sign. All right. Wanda? Thank you, Kenny.
I don't know why we didn't do all your policies when you were up there, but we thought, exercise is always
Get my
good.
last one, I have another one
Yeah,
after
I think
someone
if we
else.
could, we'll just,
Save some.
yeah, bring them all up one time.
I've never thought about that at all. I thought this was some system you had.
Of making them go up and back?
Yeah, exercise, healthy life.
It is. It is all part of our Healthy Life Fitness program.
I looked at that as well, and then I figured out why they have them this way, and that is because they have them grouped by
I'm more
chapter from the
convinced
Joint
that
Commission,
they have
so,
them the way
rather
you
than
want.
person. So I was thinking, okay, why are we up and down? So I figured that out. Okay. My next policy is Patient Care Policy 700, which is our patient education policy. The only change to this was changing the word which to this.
All right.
Okay.
Move approval. That was.
Second by DP. Any discussion?
I have a question on this one. It talks about being culturally competent, but also it doesn't speak about language, and if that information is given within their language. Is there a specific reason, or are y'all using that under culturally appropriate?
I think it would fall under the cultural appropriateness of that, rather than spelling it out specifically.
Okay.
You got it, Antoinette?
Yes.
Okay. All in favor, please say aye.
Aye.
Those opposed, same sign. Okay, Wanda, you got the next one.
I do. Next is Patient Care 400, which is our interdisciplinary plan of care policy. The only change in this policy is adding the word written to read the written plan of care may be modified. So it was basically just changing one word.
Okay. All right.
DT, second for Dorothy, second. Discussion, all in favor, please say aye.
Aye.
Those opposed, same sign. Okay. You got-
And,
Wait a second, one.
I'm sorry.
Go ahead with your guardianship policy. You're up.
I'm sorry. The last policy is patient right policy, and it is for guardianship. And the only change to this was under Roman number 1 was to refer to two other policies, which is the informed consent policy and the advanced directive policy. So it's just linking those policies together.
Discussion for,
Move approval.
discussion, all in favor, please say aye.
Aye.
Those opposed, same sign. Hey, you had a question.
Well, of course, about the policy, I question, one that said a minute ago about Joint Commission. And so we're doing word corrections or sentence corrections to be in compliance with the Joint Commission. But there's a policy that we had some time ago, we had in here, I think. So do we continue to change because they continue to say change?
We
guess
just
I'm-
have to review these policies every so many years, and as we do them, when you read through the standards, we just want to make sure it's as in line with Joint Commission as it can be, so that there's no questions when they come back to that. But we have to review the policy anyway, so it's just making sure that the verbiage is matching what their standard is for that time.
And it comes both ways. We're reviewing those policies, and we go through the chapters that not only CMS, but Joint Commission have. And then Joint Commission will oftentimes send out alerts of changes they have to their own policies, and therefore, we don't want a policy that's outdated with one they change. So it goes both ways, and a lot of this is literally word changes over time.
Oh, okay.
Okay.
Any questions? Okay, thank you.
Thank you very much.
Thank you.
Last one for Kenny.
Wanda, can you come back up? I'm just kidding.
Well, is there somebody back there that we can,
Somebody who hadn't had exercise today that needs to come up.
Diana, you want to come up? Okay. Safe medication practices.
Yes, sir. So this is a policy statement in regards to reduce the risk of medication errors and adverse events by providing JPS system-wide standards for safe medication practices, medication ordering documentation, and related communications. This policy is just here for review. The changes that were made was that we scratched out John Peter Smith and put JPS, physician to physicians, and updated the references.
Okay. Got DT, is there a second? Second by Dorothy. Discussion for Kenny. All in favor, please say aye.
Aye.
Those opposed, same sign. It passes.
And
Thank you.
we apologize, that's not us wanting to spend more time with you
Yeah,
all,
that's-
although we do, but anytime that, I mean, that's pretty much, and Dorothy, you probably remember that, that's the requirement. If there is any change in any of that wording, it's got to go through the governing body. So whatever we do, we're changing those.
Thank y'all.
Thank you. Performance improvement reports. None of these require action. The first one I have is for Laura. Come right up. You want to bring Rob with you? I mean,
No,
just-
I'm solo today. It's not as fun when you're by yourself. Amanda, I feel bad. You're over there.
I like being in a league of my own. I rise above.
A league
I
of
rise
your
above.
own. Well, good afternoon, everyone. I am here to present the patient experience information and wanted to give a little bit of history on why we measure and collect feedback so that it hopefully starts to answer some of the questions that may be out there for you still on all of the data that we collect and what it actually means. So we actually survey our patients, as you know, through a vendor named NRC Health, and we survey in a variety of ways, which I'll show you in a moment. When we survey our patients, though, it actually leads to increased awareness to our pillars as a whole. And so when our patients come in and they have a great patient experience, what we know is that their anxiety becomes reduced, their trust level in the caregiver increases, and when that happens, we find better quality outcomes. And so tactically, a lot of the work that we do measure against quality outcomes. So for instance, we just recently implemented and really reinforced a tactic on our units, and we found that our pressure ulcers have decreased in those areas. And so there's a direct connect between patient experience and quality, we know. The other part of this is when patients go home and they understand their plan of care or they understand what was said to them in the hospital, they can actually comply with the plan of care. And so it prevents them from returning either to a clinic visit or to back to the emergency room or to the urgent care setting. And so we end up finding a blend over into our stewardship pillar as well. The other part of this is that when patients are experiencing really great care, their quality improves, we're doing well financially, our employees end up being more engaged. And so it's really easy to thread the needle through all of our pillars to show that how one impacts the other, impacts the other, impacts the other. And so we measure this, but it's not just about measuring how nice we are, and we've talked about that several times. We actually survey several different areas, and I wanted to just bring this to your attention, although what we show in here is just what's related to our organizational goals, but we actually do survey in all of these areas, and we expect about 200,000 surveys returned this year. So how do we survey? That answer is it depends. Some of our surveys are regulated through CMS, as our HCAP survey is, our inpatient survey. And then some of them we have some latitude with where we can actually shorten the survey and make it more user-friendly for our patients so that it's not the lengthy survey that they get if they're on the inpatient side, but a shortened version that still gives us a lot of really good information. But we try to keep the questions as similar as we can so that we can actually continue to maintain some consistency there. Where possible, we've created those abbreviated surveys. So in our outpatient clinic settings, in our oncology and infusion center, our behavioral health, and our emergency services, we actually use the abbreviated survey. And methodologies that we use are phone and email currently. We have talked with our vendor about the texting feature, and they're not finding a huge response rate with that, surprisingly. And so we're still investigating that. And if we find that that becomes a valid method or a valuable method for surveying, we'll add that to the mix as well. And then currently we get about 30% of our surveys returned, and industry average is about 18%. Our most recent results for our organizational goals, on the inpatient side, we are hitting target at 5 of our dimensions, improving at the national average rate of improvement. And on the outpatient side, we're hitting 8 of the 10 questions. So we are at target and stretch on our service pillar goals. I included the questions for you as well, along with the dimensions. So on this slide, you'll see the dimensions on the left-hand column, and then the questions that are encompassed within those dimensions. This is for our inpatient survey. And again, the 10 dimensions that are listed on the left-hand column are the dimensions that we are working to improve according to our organizational goal. Here's our outpatient questions, and we've grouped them as well, but there are 10 questions that we ask our patients, and those are listed on the right-hand column. So what do we do with all of this data? We do lots of things with this data, actually. I was sharing with Dr. Weber last week all of the dashboards that we collect and share, and we actually review all of the data. Amanda, you've seen them too. There's lots and lots of data, but we actually do a lot of different actions along with that, the dashboard collection. First of all, we reward and recognize our team members. We do things like WOWs, VIPs, our digital display monitors. We actually include our clinician comments that come through. And so we do 10 a month of the clinician response comments that come back from patients on our TVs throughout the network. We look at all of the trends and opportunities, qualitative and quantitative, and then we work with the leaders in those areas in order to action plan and create tactics that will help them improve their results where needed or celebrate their results where that's warranted. We do prioritize all of our improvement efforts, and so we've grouped those this past year. And because the patient experience team is a smaller team, we have taken on the initiative of training the trainer within that framework. And so we prioritize and trend as much as we can so that we can train our trainers on specific things and not be covering a whole variety of tactics, but rather focus in on 1 or 2 or 3 that will help us get the best results. And then we develop our strategies to make sure that we're consistently caring and providing a compassionate experience for our patients. We tried really hard this year to bring the dimensions alive. The dimensions of care actually cover the house. So there's cleanliness, there's care transitions, there's medications, there's discharge instructions, there's all kinds of things that are incorporated within the dimensions, and so we tried to bring those alive this year, and we're finding quite a bit of success with that. We also round on all of our patients and our employees in different units throughout the hospital, whether it be a unit leader or a clinic leader or an executive that's going out and doing rounds. We spend time with our team members as well as our patients, learning from them. And then we create content for new training programs. So we recently started a certification mastery program in patient experience, and we've completed 2 of those courses now for 3 tracks. one for the outpatient leaders, one for the inpatient leaders, and one for our physicians and APPs. And there are 8 more sessions that we'll be having for that will complete this year, and then our groups will be certified in patient experience as masters. We actually meet and spend time with every employee, every provider, and every leader when they come on board. So whether it be in orientation, whether it be in a learning session, or one-on-one time, we spend a lot of time with them to make sure that they're up to speed on what it is that we need as far as taking care of our patients and what our patients are requesting. And just on the reward and recognition front, last week, Friday, we actually went to the units. We have 9 units within the hospital that are actually meeting goal, which is a huge deal. And we celebrated. We sing a little goofy song, and they get tickled. And it's bad. That's all I can say. But they like it, and they have fun, and we brought them cookies, and so we were able to celebrate them. We also brought cookies out to the clinics last week for those who are meeting goal as well.
After Laura and her team sings, they give the cookies quickly. Because you want to make sure that you're just not left with the singing part, because
it's bad.
A lot of the folks on staff were not hired for their singing capabilities, and we all proved that.
It's bad. I know. And I had to do it by myself the other day, too, and I had to demonstrate it for our language services team.
Instead of cookies, could
Say again?
Mr. Early do some cooking?
Pies or something, I've heard. So I've heard. There's actually huge requests for that on the floor, so we try to protect him as much as we can. Do you have a question, Dorothy? Sure.
Going back to your outpatient survey question.
Sure.
You know, I see the receptionist and the doctor, but don't we have nursing in the outpatient clinic?
Not in the outpatient clinics, we don't. They're actually grouped with, so most of the outpatient clinic, I should say, is provider-focused, most of the questions, because that tends to be the focus for the patient when they come into the clinic. We do measure some of these other areas, though, like access to care, which we know is not necessarily a satisfier, but can be a dissatisfier, right? And then we measure lots of questions regarding the provider and the experience that is there. That's customary. And then, but there's not actually a specific nursing question set.
I would think you would look at the medical assistants who interact with your patients.
Yeah.
Very heavily. Should be considered. They can either make it a good visit or make it a bad visit for the provider. So that would be one that I would look to see if y'all could, when you revise it, add something in there about that.
Okay. And your questions, thank you for that. We do get in that open-ended section, we will get feedback regarding good or bad, right? But the beautiful part about this survey is that we actually can maneuver it.
Oh, okay.
And so we'll look into what options we have for that. Okay. And we have done that in the past, but it's just not on the current survey.
Okay, yeah.
Laura, Ralph.
Yeah, good. In collecting the data, is there a way, or do you have in the form that determines the age and gender
Yes.
of the persons?
Yes, we do. And we can actually segment it out that way. So and that's part of what we do when we're trending and prioritizing. So if we know that, for instance, males who are within the age group of 40 to 60 are a little bit more dissatisfied than females, then we can take a look at what might that be. And in some cases, it's, it depends on the unit, but in some cases, it's a clinical fear or those types of things that with key phrases and key words, we can actually mitigate that before it becomes a problem.
Okay. The reason I ask that is because I was just wondering, when we look at when you get the input back into you, to determine where the most of our response is coming from. Is it your older adults or is it the younger adults? Because
Yes.
I noticed when you said the texting that you're still revisiting, it might be the particular age groups who will text back versus the other age groups. So.
Yeah, I don't have that information in front of me, but I can bring it. We do segment it out that way, yes.
Right. No, I didn't ask for it today. I just was saying I had to check that.
Yes, yeah. And we use that to help us as well.
When
Yeah,
you
yeah.
text, do you use mass text them all at one time or one at a time, you know?
Well, we don't actually use that methodology here. It is a new form that the vendors are trying, but their response rate has not been as high as what they would expect to see, so.
If they text from the same source,
uh,
and
DT stuff to.
sometimes the carrier put a detection on there, and
Oh.
if you text all at one time for more than 1,000 in a short period of time, those
Okay.
are considered spam,
Okay,
and they go right to the unknown senders.
okay,
So when you look at the text, it says one is regular and one's unknown.
I
Unless they
gotcha.
click on that, they will never find the text.
okay,
So they may want to go around, break them down to a smaller number of texts anyhow.
okay. I'll share that
may
with
work.
them. Thank you. I'll share that with them as well.
But Laura, when is it a question when you are coming into the clinic, how would you like to be notified? Is it by phone, email, or text? I mean, that sometimes helps define how they will answer and what you need to send. Because that's one of the questions that I'm getting now is how would you like the information, phone, text, or email?
Even receipts and all that kind of thing these
Yeah,
days, they're
yeah,
asking you, right? Yeah. So I would love to say that that is fully hardwired and that would happen every time. That is something we are still working on.
Yeah. Well, maybe
Yeah.
this should be one of those questions, because usually when you fill out your form, when you go to your doctor, that's one of the questions they are now asking, how would you like to
Right.
do that?
Yep.
That would help.
Yep, completely agree.
My final deal on this is for the outpatient survey.
Yeah.
I get a lot of compliments on the eligibility who are in the clinics. And, you know, I don't know if they come up a lot, but they are part of that whole system. So
Yeah.
think about how you can rotate a question asking about them, because
Yeah.
it's very, very positive. And, you know, we get bad news. I'd like to see a few of those.
Yeah, that's a great point. You know, to that point too, about 2 months ago, we actually did a mission moment on that group because they had made such a huge impact on a patient who had written a letter in.
Right.
And so that's a great point. And again, we do have flexibility with this particular survey.
Okay.
So we'll look at all of those.
Okay.
Thank you.
Mhm.
I have a question.
Sure.
How many touches do they use before they actually get a survey response? Like, is there a number of phone calls, a number
Oh.
of texts? and Is there an average amount?
So they will try 3 attempts, and after that, then they don't try again.
Okay. And you had said that by the end of the year, it'll be 200,000?
About 200,000 we will
And what
get.
percentage of that is a collection of our total population?
Well, it's about 30% response rate on what's sent out, which in the outpatient clinics with this survey, we actually census sample. And then on the inpatient side, it's a random sampling of patients, so.
Yeah. And they are getting it in a specific language, or is it all coming out in English?
No, it's English and Spanish right now. Yep, and then we continue to look at what other options we have.
Thank you.
Yep, my pleasure. Okay. So when we look at specific actions, I mentioned the mastery program already. We have 3 tracks running, and that is the information that you got at the last quality meeting, where there are actually 9 courses, and then I'm putting it all together that relates to the inpatient leadership team, the outpatient leaders, and the physicians or clinicians in those specific areas. We've created dyad and triad partnerships so that our leadership and our physicians or APPs can actually function and work together on different processes, on ways that we can best take care of our patients. So that is underway and going well. We also have HCAPS University, and all of our inpatient leaders have attended that, and that is repeated. This is actually, I think since I've been here, the 3rd time that we've done this. And then the Keywords at Key Times training, all of our PARs in the clinics, we've had over 700 nurses and techs, and then 550 community health employees that have been through that. And then Robert mentioned at the board meeting last week about the Ambassador Development Institute, and we had 300 ambassadors, which are frontline team members who are hand-selected from leadership to attend and become well-versed in different areas. They actually came to our ADI a couple of weeks ago, and our focus was on diversity and inclusion. And so Michelle Green Ford did a presentation, and then we broke into breakouts, and our learning team came in, and we actually worked through real-life scenarios that could come up. And the teams, read the scenarios and then really talked about what the options they had to help take really great care of patients, and we got really great feedback on that. We had, and I'll show you the results of that in just a minute. And then we also work very closely with the diversity and inclusion team on the Serving with Sensitivity, Improving Patient Outcomes sessions that you are aware of from Michelle's presentations, and really looking at who are our patients and how can we best serve them. And we will continue to do that as we move forward. And then we do have a discharge call process that we use for our patients, and we changed the way that we do that recently. And we assigned a discharge call employee to units, and so they actually will call patients from those units and say, you were discharged from my unit yesterday, and ask specific questions around medications and were they able to get those, or supplies and were they able to do that, and then they connect back with the leadership on those units to make sure that we are fixing what we need to fix if there's a problem, but celebrating some of those successes. So they ask for recognitions and things like that as well. And those are going well, and in every instance on the units where we began this, every question is moving, and they're moving significantly. That's what I showed you last week, I guess it was. So in some of those units, all of those units that we're doing that. So how effective is our training? Like I said, we do a train-the-trainer model. We do measure these, though, and our outpatients, we've had 445 people come through these sessions already, and the average score was a 4.9 out of 5, and then the quality of the training material was also a 4.9 out of 5. We have 5 classes remaining in community health, and there's about 100 people that are still left to enroll in that. On the inpatient side, we've had over 700 that have completed the training. Again, we had 98% of our input. We measure differently, so we had about 98% of our attendees that rated a 9 or a 10, and then 2% rated it a 7 or an 8, and then the rating of the professional development sessions, again, the same scoring there. And then for our ambassador program, we had 96% of our 300 or so ambassadors that came to that training that rated the day overall very effective. A couple of wins that I wanted to be sure and share with you. We're actually seeing improvement quarter over quarter on nurse communication, on cleanliness on the inpatient unit. Ease of getting an appointment has actually improved on the outpatient side, and there's been a lot of heavy lifting that's gone on with that particular area. And one that I would be remiss if I didn't mention was our MyChart and one-click scheduling that's now in place, and being able to, we're starting being able to schedule on appointments, and that has helped a lot too.
Laura, would you do me a quick favor for
Sure.
the purposes of Amanda and Zim? Would you just quickly define top box, so when they see percentage of top box, that's a term that they may not be as used to?
Yes, absolutely. Thank you. So top box means, depending on how the question is, what the rating scale is, if it's a 0 to 10 scale, top box would be 9s or 10s. If it is an always, usually, sometimes, or never scale, top box is always. And so what you see in the percentages that are listed here are those patients who rated us top box. Anything else, whether it's a 0 through 8 or a usually, sometimes, or never, you will not see reflected on any of our data. It doesn't count. Thank you. And then we do measure the front desk, and that also is improving as we go through this. I wanted to, on the box on the right-hand side, this is the way that we have measured our inpatient unit for the last several years, with just this one overall rating question, percentile ranking. So what happens is our top box score gets, on the inpatient side, gets correlated to a percentile ranking for every hospital in the country. And so what you see on the right-hand side within that box is our percentile ranking on the inpatient side as compared to every adult acute care hospital in the country. So last year, we hit the 71st percentile. This year, fiscal year to date, we are at the 75th percentile, which puts us in the top quartile of the country.
Can you
Yeah.
go back? On front desk courtesy, respect, outpatient, is that, what is front desk? Where?
Yeah, so it actually, well, the front desk in the clinic.
Or in the clinic?
In the clinic.
Okay.
But we also get feedback from our scheduling centers. So we have multiple scheduling centers throughout the network, and we get feedback on those as well as the ease to get an appointment.
Okay.
So you have the two on the left refer to the inpatient side, and the two on the right refer to the outpatient side. Any other questions?
On the ease to get an appointment outpatient, does that include just primary care or specialty also rated in that?
That is we measure for our goal, primary care and specialty care. And then, so that, and as far as our AIP organizational goal is concerned, we combine those this year. Last year, it was just primary care, but we combined that for the goal this year.
So this year is both of them?
Both of them.
Thanks.
Yes.
All right.
Other comments, questions? Lots of work going on. It takes a village to make this happen, so. But fortunately, we have really compassionate, committed people who want to do right by our patients, and we see that.
Okay.
Thank you all.
Thank you.
Very, very important. For sure. Okay. You're up, Rob.
Put it this way.
Thanks. I wanted to, if we could go on in the slides, I guess, do I have? Yes. So I wanted to go over about 3 items with you. The first is an update on our PSI 90, which is our organizational goal for quality. If you recall from last time, this is our weighted, risk-adjusted measure of 11 serious hospital-acquired conditions. And as you can see, we've really made some phenomenal progress with this goal. So we launched this goal with this fiscal year. We hadn't used it before, so we took about 1 quarter to understand this goal and to come up with strategies around improving it. The first strategy was to make sure that what we were measuring was actually adverse. So as we discussed last time, we needed to get our documentation regarding the care of our patients correct first, to make sure that what we were actually measuring were things that we needed to be measuring. The other thing I should point out about this metric is that it's actually a pulled metric. So what that means is that CMS looks at the things that we document and code in the medical records of our patients, and then on the basis of that, they identify events. Okay, so we don't find events and report them to somebody. They look at the medical records of our patients, and they identify these events by pulling them from the documentation, from the coding that they see when we are submitting bills for the cares of our patients. Now, they actually get to look at everything. They don't just look at the patients who are under Medicare and Medicaid. So this is reflective of all of the patients that we're taking care of at JPS, not just simply the Medicare patients, not specifically those who are covered by CMS programs. So in any case, in the first quarter, we had to spend some time understanding the metric. We then, with the help of our HIM team, Health Information Management team, the CDI team specifically, which is the Clinical Documentation Improvement team within HIM, so lots of acronyms, but anyway, this is an incredibly passionate team, actually, who were also the subject of a mission moment in one of our Leadership Connection meetings recently because of their incredibly enthusiastic work to try to get this documentation and coding correct. And so that's required not only work from them, but also tremendous buy-in from our providers who have to actually document these diagnoses and get them coded correctly. So with that, that is the first effort, and then with some substantial quality improvement efforts, particularly around DVT, which is deep vein thrombosis and pulmonary embolism, we've had some dramatic improvements in the results of PSI 90. So you can see the first 3 months of the fiscal year, our results could have been better. So, the other thing I should point out is that a score of 1 means that the rate of these events is at expected for the severity of the disease that our patients have. So the PSI 90 is essentially reported as a ratio of observed over expected. So 1 means we are at expected. Above 1 means that we're seeing more events than expected, and less than 1 means that we are seeing fewer events than expected. So in the first quarter, we had more events than expected. A lot of these were improperly coded events, so that we were picking up things that were not adverse. And then since that first quarter, as we've made these efforts in clinical documentation and quality improvement as well, we've seen really consistent, strong performance over the last 5, and now the June result will also be strong. So over the last, quite a few months now. And the really good news that we have, which is updated from last time, is that we are now better than goal for this particular measure. So we had a target of seeing essentially as many of these events as one would expect, and now we are seeing fewer for the whole year to date, fewer of these events than we would expect. I'll break that down for you just a little bit here. So this is our scorecard for all of these events, and you can see that for the majority of them, we've seen some pretty dramatic improvements. You'll notice things like PSI 11, which is the postoperative respiratory failure rate. We've seen a dramatic improvement there. You can see PE and DVT also beginning to improve, which is great. And you can see postoperative hemorrhage is improved. Our pressure ulcer rate, to Laura's point earlier about the relationship between outstanding patient experience and a quality measure, you can see this actually now reflected in our rate of pressure ulcers in the hospital, and this follows along with some of the work that her team has been spearheading, and everybody else around the organization has been carrying the freight for that very strong effort. So I'm very pleased with this. Obviously, this requires sustained effort to hold on to these gains, and as I'll point out in just a moment, sustaining these gains will have some major positive outcomes for our organization. So the next thing I wanted to talk about with you is our spring leave.
Excuse me,
yes,
before
please.
you leave
Yes,
that,
please. Mm-hmm.
what's going on with our septic rate?
So the postoperative sepsis rate. So very good question. So there are very few events baked into this because the rate is supposed to be very low. The sepsis...
Eventually it will happen.
What are they talking about?
So postoperative sepsis is a little bit complicated. If you'll bear with me for a moment, I will describe in a little bit of gory detail exactly what goes into that rate. So to qualify for the postoperative sepsis rate, you have to be admitted to the hospital on a non-emergent basis, and you have to have had something that is called surgery according to DRG, so Diagnostic Related Groups criteria, and you have to have also had sepsis. So you have to have those 3 things. They don't have to be in any particular order, however. I guess the admission has to be first, but the other 2 don't have to be. So for example, one case that was frustrating from the fall was a patient who had been admitted for chemotherapy, developed neutropenic sepsis, had multiple strokes, and then subsequently needed to have a feeding tube placed and a tracheostomy. They had no sepsis following the tracheostomy placement, but that tracheostomy put them over into the surgery diagnostic-related group. So, that ended up being a sepsis, but it was certainly not related to the surgery. So it's a bit of a it's a bit of a quirk of the situation. Why is it so high? Part of that is because of the nature of our patient population, which is a very high acuity patient population. The second thing, and this actually is going to be a little bit interesting to see the impact, but weirdly, bronchoscopy is considered a surgery, although endoscopy is not considered a surgery. This is actually changing in the fall, and there are many, many weird things about some of these measures. So I'm just trying to open the book and explain it a little bit to you. But so in the fall, bronchoscopy, I think in October, bronchoscopy is no longer going to be a surgery according to DRGs, and this is likely to impact teaching hospitals in general more than non-teaching hospitals. This is not immediately obvious as to why this is, but for those of us who have practiced in these sorts of places, you'll understand pretty quickly. In non-teaching hospitals, in the ICU, if a patient needs to be, maybe has mucus plugging or stuff, the attending physicians will typically order some endotracheal suctioning and this sort of thing. In a teaching hospital, frequently they will instead do endotracheal suctioning under direct visualization and do through the endotracheal tube bronchoscopy. This is very frequently done in teaching hospitals, but not in non-teaching hospitals. So I think we're going to see, and quite a few of these sepsises are precisely in those kinds of patients who were admitted to the ICU for some other reason and ended up getting a bronchoscopy as part of the management of their pneumonia or whatever it is. So I expect that this particular measure will change quite a bit for teaching hospitals going forward, because that bronchoscopy, that essentially endotracheal suctioning under direct visualization, will be removed from the equation for this particular measure. So please forgive me for that extended explanation, but there are some weirdnesses in some of these measures.
Yep. All right, thank you. No, after he went through that and told me, somehow the patient did have sepsis. Somehow they got an infection. Eventually, it was an infection there.
There's no question that these patients got infections, but as you know, that for example, going back to the patient with neutropenic sepsis in the middle of a chemotherapy treatment, there may well be opportunities for improvement in that, but those things do occur certainly in that patient population at a higher risk rate than for other patients.
Okay, all right. But when we're looking at that, other hospitals have patients come in and have the same problem, and they're getting chemotherapy. Their rates are not as high, they are identified too, right?
True, there's no question, and I think there are opportunities for improvement in sepsis. I wouldn't deny that. I'm just trying to point out that there are a few weirdnesses in the measure as well.
Right.
And and the great thing about going back to the whole PSI 90 project in general is that it has given us an opportunity, now that we've tuned the machine, if you will, and that what we're measuring as adverse is more often adverse than it was before. Before, I think there was a lot of issues with documentation and coding, and now we've sort of sorted all that out. So when we look at things that are outlying, like our rate of DVT and PE is still 3 times greater than we would expect, or our postoperative sepsis rate, that has given us opportunities to bring together work groups to evaluate these areas and to come up with action plans to address them. So this is really where we're going with this project now, is that if you go back, you can see the things, as you've noticed, that we've got some things where we're still outlying, and those two, DVT and PE and postoperative sepsis are the 2 areas that clearly stick out there, and those are the areas that we're addressing with work groups and action plans. So I wanted to go over our leapfrog results from the spring. So we had a couple of years of where we had gotten into the B range, and we slipped back to the C range for this spring, which was disappointing, certainly. There were some opportunities for, the one thing I will say is that we missed B by the narrowest margin. If we had been able to take full credit on either one of these measures, barcode administration, medication administration we've been doing for a while, but there were some features that were required in the spring survey that were not possible in the EPIC version that we had running through most of 2018. We had an update at the end of 2018. Now we are able to take full credit for that particular measure. We got 75 points out of 100 for that. Now we can get 100 out of 100. On the other, the SP2, which is culture measurement, feedback, and intervention, we were able to get 100 out of 120 points. We missed the 20 because we didn't have structured feedback and performance evaluation to our executives based on the results of the AHRQ Culture of Patient Safety Survey, which is recommended as a best practice. In advance of the fall survey, we have closed that gap, and so we anticipate that that's going to be better. All that being said, actually, I would anticipate for the fall survey that we will not see an improvement in the score, in the final grade, and the reasons are a couple. Number one, based on the date ranges of the material that's gathered. So actually, let me back up just one second and just explain what goes into Leapfrog. So there are several things. First, our safety practices, which are best practices in terms of organizational effort around a whole variety of different activities, whether it is barcoded medication administration or safety practices or whatever. But anyway, there's a whole host of those, and you simply have to demonstrate, you have to be able to document that you're doing those things. So it's just a whole collection of best practices. So, that's, for these surveys, that's really what I consider to be low-hanging fruit. They tell you do this, and you do it. And one of the things that I've been trying to emphasize to my team and to anyone who I end up in front of for any reason is to always ask, why are they asking us to do these things? In other words, to say, as opposed to just trying to check the box, to say, how can we leverage something like going after better Leapfrog performance to actually make us a better organization? So obviously you want to be able to check off all of those boxes. And then the second half of the survey is to look at our results for a whole bunch of different outcomes. Some of them are patient experience, which obviously, as you can see, according to the data Laura presented just a few minutes ago, we're seeing some really strong improvement in experience. 3 measures of experience: communication with doctor, communication with nurse, and communication about medications are all baked into the Leapfrog survey. Results in terms of several hospital-acquired infections, as you can see up here, CAUTI and CLABSI, which are catheter-associated urinary tract infection and central line-associated bloodstream infection, are on the list. Our rates of MRSA and bacteremia sepsis is on the list. Our rates of things like Clostridium difficile infection are on the list. Surgical site infections in colon surgery are on the list. And then, as it turns out, from the PSI 90 data, 6 of the 11 measures from PSI 90 walk straight across to Leapfrog. So the reason that so if we go back to the survey from the spring, we had very strong performance in CAUTI and CLABSI. This isn't surprising because the date range that they were looking at was overlapped with when we had these 2 things on our organizational goals for quality a couple years ago. These other measures we were not performing as well during the period, and again, this is because, number one, the date range that was being looked at for surgical site infection for colon was before we had begun addressing that as an organizational goal. And the PSI 90s were not as good because we hadn't started looking at that either in a systematic way. Going forward, though, with our strong performance in PSI and the fact that we've actually kept our eyes on the colon thing, even though it's no longer on the organizational goal, I would anticipate in future surveys after the spring that we may well see some significantly stronger performance in Leapfrog. Any questions about all that? Coming up as a future thing, as future issues for Leapfrog, there are three real main changes that we're looking forward to already for what will probably be important for the spring 2020 Leapfrog survey. There are several new asks from Leapfrog regarding high-risk surgical procedures. One is volume minimums for certain high-risk procedures. These include things like pancreatic resection, esophageal surgery, open aortic surgery, mitral valve repair or replacement. And then they've also asked us to develop appropriateness criteria or adopt appropriateness criteria for each of those kinds of procedures. We have actually gone ahead and done that already, so we are ahead of the curve on that. And those things will be reporting up through a high-risk surgical committee, which has been formed under the leadership of Van Johnson, one of our relatively new trauma and critical care surgeons. Hand hygiene is going to be a big issue going forward as well. We need to be presenting Leapfrog with specific plans around improving hand hygiene, and we need to be coming to you as the board with our results and our plans. And so you can look forward to that as coming attractions as well, probably this fall. Finally, yes, please.
With the PSI and Leapfrog, are our dates off on when they're looking at the information? Is one of them at one period and the other one? Yes. Because you look at the PSI and then I'm looking at Leapfrog, your accidents and cuts and tears.
Oh, yeah.
Yeah, so.
Oh, yeah, there's no question.
Okay.
So there are big differences, in fact. And there are differences within the Leapfrog survey as to what hits when. So, for example, for Cowdy and Clabsy and surgical site infections, so all the hospital-acquired infections. For this current survey, it went from mid-2017 to mid-2018. So I'm anticipating for this fall survey, it'll be calendar year 2018 is what they'll be looking at. We don't 100% know, but I'm just charting from past behavior.
I can dig on down in that, but
Right.
PSI dates are more current?
No, so PSI is way delayed in a way, actually.
Okay.
So PSI for this survey actually tracked from October of 2015 to June of 2018. Okay. So one of the reasons they do that for the PSIs is that they're relatively rare events. Mm-hmm. So given that some of these things are rare, if they looked over too short a period of time, you could imagine that there could just be fluctuation based upon when events hit. So they've intentionally given a fairly broad collection time in order to keep that measure relatively smooth, survey to survey for an individual hospital.
Okay. All right, thank you.
Okay, sure, absolutely. But anyway, and for outpatient surgery, again, it's things like looking at appropriateness of patient selection for outpatient surgery, as well as making sure for outpatient surgery centers there are appropriate transfer agreements and that sort of thing. I think that for us will be fairly low-hanging fruit. We're already in pretty good shape in terms of how our ambulatory surgery center is utilized. So I don't think that that's going to be a particular challenge. I think the one challenge out of this group is that because we are a public facility and a lot of our patients can't go elsewhere for surgery, and it's also difficult to become a major referral center for some of these kinds of surgeries. We are obliged frequently to do some sorts of surgeries at relatively low volume. So given that we know that, it just means that we have to perform all the much better in the remainder of the measures to make sure that we get the grade that we really should get. I mean, quite frankly, I think that I would expect a much stronger performance in future surveys, but this fall one, I think we're going to be still in the same range.
No.
Just to put it in perspective for y'all, and I know I've mentioned this before, but the evolution of this organization in regards to Leapfrog and quality checks has come a long way. Mm-hmm. In 2008 and 2009, we had a quality team who had a great opposition to Leapfrog and thought the Leapfrog information was irrelevant and shouldn't be done. And it was recommended to us as staff, from our own staff, let's just not respond to leapfrog. Never a good idea, but JPS started behind from the very beginning, and they've continuously tried to improve in certain categories. As Rob mentioned, it's not an excuse, but some of our areas in some of our surgeries are smaller percentages, so it is that much more important for us to be higher in the quality at which we provide. So it is a challenge, but we'll be very upfront with you about what that is and where that is and how we compare, because for you as board members, you are going to hear that. Well, I hear you guys got a C, and you should be prepared to understand what that is and why, because you will get questions from the community about that. So I appreciate Rob and his efforts and his team and the quality team overall, not only putting an emphasis behind this, but Rob said the key word. This is not about leapfrog. This is about the best way you can run a healthcare network for outcomes that are positive for our patients. We don't want a low grade. We will obviously celebrate if we get a high grade, but the grade is secondary to what we're performing and what we're doing for our patients. So, Rob, I appreciate your efforts.
Thank you. The final thing I wanted to show you was, and this was a bit of a coming attraction as well for this committee, is that by chart and by best practice, frankly, our chief administrative quality committee should be, by chart reports to this committee, the Board of Managers Quality Committee. As a coming attraction, you will be receiving the minutes from this committee, but I want to show you what actually goes into this committee in terms of a structure, and I know this is a very busy slide. The two big changes in this structure, because as you can see, there's all kinds of different programs, and for example, some of our key initiative programs, like our stroke program, our sepsis program. I should mention that our stroke program was re-verified in the last couple of weeks with essentially no significant deficiencies at all. I mean, there are a couple of pointers for the future, but was given tremendous commendation. Particularly, the one thing I will mention especially is that the percentage of our patients who receive either thrombolytics or catheter-based interventions for their stroke is off the charts high here. So we are really performing at a very, very high level. But as you can see, there's a lot of different things that report into this. The two I really want to bring out, though, are two new groups that have been formed, and they sit right underneath the PSQG, which is our Quality Council and our Patient Safety Council. So Quality Council is tasked with looking at basically our large quality data, evaluating it, and then developing work groups and action plans around different gaps and vulnerabilities that are identified through larger measures. And for example, this is the group that has taken on the effort of improving our performance in deep vein thrombosis and pulmonary embolism. Their chairman, Dr. Fromm, who's also our chairman of anesthesiology, in addition, has a particular passion around the issue of handoffs and handovers, which is one of the major causes of safety issues, for our patients, and not only here, but in all healthcare organizations, to make sure that communication from one person who's taking care of a patient to another person who's taking care of a patient is structured, meaningful, reproducible, and reliable. And so these are the two major initial efforts that are coming out of that particular group. Our Patient Safety Council is responsible for monitoring all of the outcomes of all of our root cause analyses that are done for not only the sentinel events, which are presented to this body, but also for the serious safety events that are not deemed by Joint Commission to be sentinel, but nonetheless are frequently very, very educational to our organization in terms of understanding our vulnerabilities and beginning to attack them in a meaningful and broad-based way. And so this group is tasked with going through that. The discussions are very robust and frequently lead to further development of action plans, that are even more meaningful because we get an even broader base group at the table than we have for our RCAs. The one thing I will say about RCAs in general, since I bring up Patient Safety Council, is that we're now doing them in perhaps an even more robust way than we ever have before. And I'll give a lot of credit to Dr. Hochberg for driving this, but he's elevated the level of attention on all these events to a very high level. We usually have multiple executives in the room for any root cause analysis. We also make sure that there are appropriate physician leaders, not only the physicians involved, but also service line leaders and that sort of thing, which obviously creates the opportunity for a very high-level discussion and very, very meaningful action plans. So it's the role of this particular Patient Safety Council to evaluate those action plans and to make sure they're robust, meaningful, and that as sometimes can happen, the cure is not worse than the disease, so that the solutions that are applied to one particular situation don't cause issues for other departments or groups or other aspects of patient care.
I want to make note, particularly to you, Pastor, that this is the first time you have received an org chart that you didn't ask for it. That's how advanced we are now. We're getting org charts out and you didn't even request it. You may not even like it, but we got one.
Are there any questions about any of this aspect of our quality program?
I think it's pretty damn good.
Thanks, Rob.
coming
Appreciate it
along.
very much.
Thank you.
Agenda, we have a couple little things in closed session. So with that, we'll temporarily adjourn at what? 14:17. Come back in about 5 minutes. How's that? All right. Very good.
Those of you staying for the next committee meeting, it will start at 3:30, so you got a little bit of time to
Okay.
take a break, but
I want Petty to know
that you got done on
we
time.
got
Thought
done.
we started
I
at
will
3.
let him know that very fact. But we can't start the next meeting any earlier.
Any
You have
earlier
to
than
start when it's
3:30.
posted, so
Yeah.
3:30 time. And there's no way you can know, we always have this issue, but there's no way we can know. So 3:30.
It could have been worse if Chuck would have been right.
Good afternoon, folks. We appreciate you being here. It's about 3:30, and we are slated to begin our agenda on the Planning Committee at 3:30. Welcome to all of you. I'm informed of no citizens wishing to address the board.
Do we have, let me make sure.
Unless I
because
didn't
Do
know
we have
one.
anybody signed up? I didn't see any signatures on there. Okay, super.
Okay.
I just want to make sure.
Seeing none, then we will, let me give you a kind of an overview of the agenda today. We don't have a lot of items. We do have some lengthy discussion that we want to be able to have. Probably going to be an executive session in addition to that. So while it's not a long agenda in terms of items, it is quite a bit of discussion points. So, Robert, anything on the CEO update?
No, I do not.
Okay. You should have your minutes from your May 2nd meeting. Anybody had any observations about those? If not, we'd entertain a motion. A motion for Dr. Weber, second from Reverend Emerson. All in favor, say aye. All opposed, same sign. That's that. Thank you, sir. Okay, so all of you have been very patiently waiting on the next steps relative to the bond project. And I speak for the board, I know, in thanking people for their patience and for their support for that project. It's been a long time coming. It has also been a long time since we really had a chance to sit down and start talking about details related to it. One of the factors that was a delay, I'll call it, in us really being able to get together and discuss this at length was the fact that we weren't sure what was going to happen with our friends in the Texas legislature this session and what would happen to hospitals, public hospitals. The good news is when compared to what happened to cities, compared to what happened to public hospitals are in great shape. So cities are not. Cities are not. Roger,
And we feel bad for you, but we are delighted, and we are very thankful to our legislative body.
Roger and I can attest to the fact cities are not. So anyway, that was a huge issue for us because had there been substantial changes made to how we are able to calculate our effective tax rate and caps related to that, that would have had a huge impact on bond deployment. And to really head off in a direction without knowing that was kind of irresponsible and a waste of everyone's time. So since that's been resolved, we have been meeting, as you know. There's been an ad hoc subcommittee that has been looking primarily at process related to the bond deployment. This committee really hasn't done anything relative to decisions yet on what needs to be built and when it needs to be built. That has always been an area that the Commissioners Court has really looked carefully to the board to advise them on. And so today we're going to start that process in earnest. I've asked the staff to put together quite a bit of information for you. I hope that you all got a chance to either review what you've already read or if you haven't read it at all, the past reports that go all the way back to Boca Powell for the board's actions relative to master campus planning, the HCA reports, the Cummings report, the Blue Ribbon Committee. I mean, there is enough paper here to choke a mule when it comes to the amount of work that's been done to get us to where we are today. That's preparatory in terms of, recognizing that we have sort of in a point where we're going to have to assimilate a gigantic amount of information down to some pretty simple steps and pretty simple calendars that we now have to begin, adhering to. So with that, before we bring the staff up, one of the things I've asked to do is I've asked the staff to bring us sort of their perspective right now on where we are related to the history of this activity. I knew that the committee, and by the way, we will be acting today as the board since we have a majority of the board present, and this was published as a board meeting, so we can avoid having to take additional steps on this. But because we wanted to, get to a point where we could make this move as quickly as possible, I really wanted the staff to be able to present to you their perspective on the recommendations that they see today. Where are we today at JPS? What are the facility needs? Obviously, a lot of water has gone under the bridge. There's been a lot of changes, a lot of activity since we last met relative to campus planning. I didn't really want us to have to go down a trail chasing rabbits if we hadn't heard the staff's communication on this and their perspective and their recommendations. So we've got a lot of background data. We're more than happy to keep this agenda very fluid today and be sure that if you have questions at any point, that you stop the staff and that you ask them those questions, because we'll spend as much time as necessary to make sure that there's adequate discussion and there's clarity on these items. So that's really our key for the day. So with that, Robert, let me turn it over to you, and I know you're going to bring up the team, and we'll jump
bet.
in.
I appreciate it, Mr. Chairman, very much. And a couple comments that I would like to make in addition to Trent's articulate outlining of that is, I'm a big believer that the balance between the court and the board can be very amicable and valuable. The court has a very vested interest in this. These are elected officials that have a duty and a responsibility to their constituents. They're also the people that put this bond package on a ballot. And you all as a board have the particulars of knowing what goes on here and the luxury of having monthly meetings and in some cases what appears to be daily committee meetings. You all are informed in everything, and that synergy between the two I think is going to be hugely beneficial as we go through this bond package. To Trent's point, aside from the ability to choke a mule, we also have a trend that you can look back. If you go back to the Boca Powell project way back in 2009 and 2010, you read through that and then you go through some of Blue Cottage's reports and you go through HMA's reports, you'll see the trend. None of that amount of paperwork gives you a diversion in the direction that we've been taking. So in that regard, I think where we want to be, where you as a board want to be, where our Commissioners Court wants to be, is all focused on the patient and our responsibility from a stewardship standpoint to the community that provided us the funds to do this. And that's where we're going to be, and that's where staff is going to emphasize what we're going to look at. So what I like to do is have Bill come up, and I'm going to have Lou come up, and I'm going to have Angie come up. These are three talented folks. Obviously, you all know them. We have moved Lou Mattingly into a new director's role to allow Lou to help us with some of the initial construction aspects and help us with a lot of the work that we're doing on the bond as we preliminary get into this. You're at some point obviously going to have an outside source which helps manage some of these things, but Lou is a very talented person at trying to help us with some of these. So I'm going to let them go into some of the details, but what I wanted to do is let you all know that and we'll go into more of the details of the recommendations, but the way we as staff see things is we have an opportunity to jumpstart this process in a very good way, because there are construction designs and there are architects that have been in place for the prototype of our Northeast Clinic. When we put the Northeast Clinic in, it's our last clinic to go in. We were groundbreaking that 9 months ago from here, and that can be something that we can bring to the community for other sites. Mr. Chairman, you and Steve both know that your work on the Blue Ribbon Committee suggested that there be 4 outreach facilities. We ultimately want to get to 4. Maybe we want to get to 5 or 6, but at this time, we as staff would recommend that we start that process with 2 locations. And before I even finish that statement, that begs a question from half of you, if not all of you in the audience, is where they're going to be. Because that's where the lick log starts, and that is, where are they going to be? We're not at that point. We can tell you, looking at preliminary site maps, looking at where we would go, we think we can begin to address, and I don't want to go too far deep into 4 locations immediately, because it's an ever-changing process and need for JPS, but I think we could begin to address some of the initial needs of this community and our county if we looked at 2 facilities. So the staff will go into a little more detail about that, but I just want to have y'all hear me. We don't have site locations, and the purpose of this meeting today is not to pick a site location because we're not prepared for that yet. But we are prepared to let you know that it would be a facility that has been doing quite well in the Northeast, and that is a prototype for us. The second thing that I would want to communicate to y'all is what Trent you and Pastor Emerson and Dorothy and DT and all have worked on, and Chuck have worked on for so long, and that is, how do you enhance patient care services here? The challenges that we have with having clinics on the second floor of this building, which a waiting room is a hallway, which the actual procedure room is the size of the trunk of your car, and it's challenging, and it's been a challenge for a long time. The other need of aspects of other patient care services, you all approved of an architect, and we talked about an ambulatory surgery center, and in the Blue Ribbon Committee, it brings up the ambulatory surgery center. We would like to, for vernacular sense, change that to a patient care center, with no offense to the Blue Ribbon Committee, because it includes more than just ambulatory care. It is a patient care center for a variety of things. And let me throw out the next caveat there. We are not prepared at this time to tell you what's on each floor. Staffs, we just mentioned this a couple weeks ago to the executive team, and all of them had 45 different ideas on what should go on each floor. It was interesting because it meant they all cared, because it was all myopic to them. And I appreciate that. That's a team you want. But we're not prepared to say it's 5 stories or 8 stories. We are prepared to say we think the organization needs a patient care tower. And I can assure you one key item would be, and I will say this, is moving those clinics off the second floor of this building and moving them over there, and then increasing your operating capacity, which quite frankly, in all honesty, should have been done back in 2007 when they built the pavilion. When they built the pavilion, all they did was move the number of ORs from this side of the street to that side of the street, and we've been paying the price for that. So looking at OR expansion, looking at the ability to have your clinics move are 2 key efficiencies. Then the third thing that we as staff looked at is the critical crisis we have of having a psychiatric emergency room on the 10th floor of a building. That is, for all practical purposes, not very smart. And we really want to be a smart organization, and we put folks at a higher level of jeopardy by moving them from floor 1 to floor 10, the challenges our police officers have in dealing with that, and it's just a movement of patient, particularly a volatile patient, you don't want. So it makes a great deal of sense to have a psychiatric emergency room on the first floor. So our initial thought was, let's take that psychiatric emergency room and put it next to that patient care tower. The problem with that is, when you look long-term, and our long-term goal is to create a new mental health facility, you start running out of space over there pretty quick. And it's not the space so much for the building, because we could cram it in. The problem is all the traffic that you got from a transport standpoint with police officers, people drop off. If you put everything on that side of the street, it makes it very, very difficult. So we know that ultimately what we've looked at and what others have recommended is your mental health facility and your improvement of that in the future is probably somewhere located right close to where Trinity Springs currently is. So why don't we be smart, and in this first level of care, let's put a psychiatric emergency room next to Trinity Springs. That immediately gets us out of the pressure valve we're in right now with the 10th floor. We can expand its space, get it on the first floor, connect it to Trinity Springs. On ultimately 3 or 4 or so years down the line, when you know you're going to need when we have the ability to build the new mental health facility, it's going to be in that area. So you then, as a board, and we as a staff, are not building something today that we look back in 5 years and go, why did we build it there? We're building it there for ultimately where your mental health facility goes, whether that's a 10-story building or a 2-story building or a 30-story building. It won't be 30, I don't want to scare the city. So in that regard, those are our recommendations for that. And then the last thing we would do, the greatest dissatisfier of you all as board members, our patients, our community, our guests, and the people sitting out in the audience, is parking. Hands down, biggest dissatisfier here. Now, it is a good litmus test, because anybody wants to come visit us, if they park here, they really want to come here, because it's a challenge. But if we could look at parking, and we could put that in that first part. So let me recap for you all some of our thoughts as staff. We can move quickly, efficiently, and expediently on behalf of our patients to look at expansion of 2 community clinics. Without a site selection at this time, I think that's a good beginning and a start to address the community needs, not all, but the beginning of them. Then we look at the establishment of the patient care center, which you've already got an architect already in line. We put that patient care facility there, and you can begin to address your OR issues and some of your clinic issues that you have here on campus, along with other services that we would come back to y'all and define in greater detail. Then you alleviate the 10th floor challenge that you have with the PEC, and we are struggling there. We are way beyond our capacity, and it is a challenge for our patients and our employees. And the quicker we could do that, the better. We would in all likelihood have to go out for an RFP for that, but that is, correct me if I'm wrong, 26,000 square feet? Is that about what that is?
728, somewhere in there.
27,000 square feet. That is something that an RFP we don't think would take an exceedingly long time. So we would hope between 18 and 24 months to be able to have that project. We would hope. I'm looking at people in the audience, they're just gulping. But I want to move in that direction so that we could do that. Hello, Mr. Powell. So we could move in that direction and alleviate a real significant pressure point for us. And then the last aspect of that would be looking at the parking garage. So we thought, Mr. Petty and myself thought it might help you all as board members if we gave you that recommendation first, and then you all begin to discuss it and figure out if that's the right way. This is just us as staff looking and saying, we think these address our immediate needs right now, but we're happy to have discussion, and your 3 experts are sitting in front of you.
So one thing to keep in mind, sort of globally, there was really 4 criteria that the staff looked at to put this together. And they were urgency of need, time to delivery, capital cost, and capital net impact. And those have all been factors that we've all discussed. We know that, the most expensive element of the entire bond program is going to be the inpatient hospital, the tower. Hundreds of millions of dollars, no question. Gigantic impact on operating taxes. So as I worked with staff to make sure that we had this framed in a way that the committee could really look at it, I think objectively, those were the 4 things. Let's make sure we're looking at the most urgent of need. Let's look at the things that we've got the capital to be able to deploy immediately without a gigantic net operating impact, and let's look at, in terms of capital cost, how can we get this done? And honestly, we're trying to work around a $200 million number. I mean, most of our effort has been trying to look at this first goal of about $200 million or less, because from Sharon's perspective and staff's perspective, and I haven't talked to you, but the financial capacity of this bond, effort is not paying for an $800 million bond off the top. So we had to put this into some perspective to hopefully eliminate, to identify the low-hanging fruit, if you will, and those were the 4 criteria that we sort of applied in doing that. Mm-hmm. So with that, Bill, however you want to proceed, we will.
Well, be happy to answer questions. Thank you, Robert. That was a great presentation.
I have a question. On using those 4 priorities, one of the concerns that I have is in your ER, you now have all of the boarding. So with the site facility being closer, the things that we're doing, will that impact that? That's my one question.
Yes, it will.
Okay.
Bill, is your mic, I don't know if your mic is on,
It is.
I can't tell.
It is. So, since January 20th, the purple elevators having been closed, all of the patients that are coming voluntarily are coming to the ED.
Oh, okay.
With the new PEC and having access to that, that's going to mitigate some of that volume,
Okay.
right?
Also, Dorothy, to that point, Bill, you might want to remind her of the expansion that we already have coming online. It's not huge, but you can remind Dorothy of that, which you've already approved.
So hopefully by October,
October 1.
we will have another 15 beds in the
ED.
ED. It's
Okay.
about 6,000 square feet of expansion.
Okay.
That was the result of building the east invasive lab building, 4 years ago. So that will help tremendously as well, in addition to changing a lot of internal workflows, and in addition to strategically looking at that going forward in 2020 and trying to determine how we can best stem that tide.
Okay.
There's a lot of folks coming there that don't need to be there.
Right,
Right.
okay. All right.
From an operating and maintenance perspective, if you look at the projects that Robert has outlined, there's going to be an increase in operating expense for the 2 new clinics, if that's the direction that we choose to go.
Okay.
We're not consolidating. We're putting them in locations that currently are the catalyst and the generators and the genesis for some of the volume coming to the ED primarily. Hopefully, we'll address that, but that's going to be new expense.
Okay.
If you look at the patient care center, it's really just transitioning things that we're doing today into a new, more efficient building. Now, you're going to increase some of your depreciation, obviously, with new construction.
Right.
But for the most part, the staff expense stays the same. If you
Yeah,
look at the
should.
PEC, we're spending approximately $16 million a year for the Psychiatric Emergency Center. We've got space for 36 chairs, 36 patients. We're averaging 55 every day. But that staff can then transition to a new building, a more efficient building. So there's really no substantial increase in expense for that either. The garage will bring some sort of depreciation expense for us and a little bit of maintenance expense. But as Robert pointed out, that is probably the most significant dissatisfier of anyone that you speak to that sets foot on JPS property. And that, if we could do that and alleviate the parking situation that might come about as a result of putting a psychiatric emergency center on an existing parking lot, in addition to staff who have to park remotely, huge win for patients, huge win for the community, huge win for staff. So think at it from an expense perspective. Yeah, we're going to have some principal and interest, right? And we've factored that in on this first tranche. But the true expense is going to come in the clinics. And if you look at Northeast, which is the template that we're looking at with the slight modification of workflow internal, but the footprint is the same, we're spending about $10 million a year on operating expense for that. So that would be in addition to the current expense structure.
Let me follow up on 2 things that Bill mentioned. When we looked at the Northeast, we were located in an old hospital, and it was not conducive to the flow of a clinic. So it was fairly easy to transition that building out, build a new building, and move staff over. We don't know where the next site will be, but you're not going to tear down your facility at, name it, at Como, and you're not going to change Viola Pitts. It would be an addition to. You don't have that circumstance at any of our existing clinics. Possibly, you could look at a few of them, but our major clinics, you're not going to, and even looking preliminary at maps, where you've got your population growth increase and where you've got your population, not only population growth increase, but the JPS traditional patient population increase, you're in likelihood don't have an existing facility. So Bill mentions appropriately, we do have to take into consideration the additional cost of staff, maintenance, and operations. Now, the one thing we don't want to forget is our Arlington facility, which has always been an attempt for us to put square peg in round hole, which has never gone particularly well. I don't think the genesis of the purchase of that building was probably the right thing for the organization to do, or at least challenging. That building has been for sale. When we first put that building up for sale, we got a lot of interest until we told them, can we lease it back from you for 4 years until we can build our new building? Nah, it's like giving a kid a bicycle and say, but you don't get tires for 2 years. So it was a little awkward, so those who were interested in our building quickly did not have so much interest. But if we are able to build the patient care center, that personnel that's currently in Arlington will transfer over. So your M&O will increase slightly, but it will not increase from 0 to whatever the dimension of that cost is. You're going to transfer others, and then you're going to have a slight financial bump on the sale of that property as well. And we've been very disciplined in not selling off pieces of it. We have people that want to buy 1 or 2 acres next to it or whatever. That is a package deal at this point, and we're continuing to work at that. So you do have a little bit of a bump in personnel and not a huge M&O increase. And then you have the bump of whatever the sale of that property would be, because Arlington, as we know, in that area has grown quite a bit, particularly in the commercial area, from when they initially bought that hospital, I don't know, back in 2003 or 2004, whenever they bought it. I don't remember. So that just gives you all a perspective on those. Thanks for the question, Dorothy.
Other questions on the recommendations, and also questions on the reports. Some of you hadn't been here when those reports were built. If you have questions on any of those reports and how those reports ended up on our desk today, now is the time. I mean, if you follow Blue Ribbon at all, you know there was no parking garage, quote unquote, in the Blue Ribbon recommendation. But when you read the report, there was a parking garage in the recommendation because they had to support the existing building. So everything that you've heard from staff was on the Blue Ribbon Committee report, and everything was considered high priority on that report. So I don't think the staff has deviated from where Blue Ribbon intended to go at all with the recommendation today.
I've got a question regarding the community health clinics. We like Northeast. I mean, we like the way that it's turned out and the design. There needs to be some changes. And you mentioned going out for an RFP. And why, like, when it comes to architecture, why would we do that?
You wouldn't.
You wouldn't.
Okay.
Okay.
My reference to the RFP was for the emergency facility for psych.
I got you.
Garage.
Okay.
We don't have that.
I was going to say,
yeah.
because that could get moving pretty quick.
No,
if
we could. And that was to Trent's point, the expeditious nature of being smart.
All right.
So the clinics would already be taken care of. The only element we don't have that we would want to be certain to be following procedures that are wise for us to, and that would be to go out for an RFP for the psych emergency building, which is the 27,000 square foot, 1-floor building.
And the garage.
And the garage, yes. So that kind of puts things in perspective for you. We truly feel as staff, this is a very smart way to start the bond, and it's a very smart thing. You're going to have to build clinics. No doubt. Nobody would disagree with you. We think this is the best start to that, and we think some of the other ancillaries would be. And then to Trent's point, as we begin to do that, then the big issues after that is the tower and a major mental health facility at some point at this time. The luxury of slightly waiting on the tower is that much more time to watch the various changes in healthcare, because what we don't want to do is build a facility with 800 beds when we should have said, you know what, we probably should have built one with less beds because of the nature of healthcare and its delivery from either telemedicine or home care delivery, those type things.
Bill,
You'll follow up, Roger? I'm sorry.
Bill, you mentioned the Community Clinic Northeast is a net $10 million expense annually. Is that
Gross.
I'm sorry?
And well worth it.
I'm not denying that, not doubting that a bit.
That's gross expense, not offset by any revenue.
Right, and so it's a net expense. So do we foresee all the community clinics kind of being the same?
We do.
Financial structure?
We do.
So
You know,
2 more is net
I
20
don't need
million.
to remind you, but let me talk about a mental health component, because there's some lessons learned from the Northeast Clinic, and we need, the next time we do this, to be able to think about expanding behavioral health. These clinics are going to have a significant behavioral health component, significant. And other services that are out there, we need to think about how we might expand those too as the need grows. So internal flow, I think those are minor issues, but yeah, mental health is a focus
Have you discussed what your overall mental health for the community would be? I know we talk about there is going to be some expansion, but have y'all sit down and really decide, here is where we want to go with mental health? I mean,
Well, we seem to be the epicenter for mental health right now. If you look at the number of transports, perhaps, from MedStar, which is not all involuntary but voluntary, right? 90% of all the transports come here. If you talk to municipal police departments in Tarrant County, surrounding counties, by practice, not by law, they bring all detention warrants to JPS. And they question what we thought we know, but that's by practice. That perhaps needs to be examined as well. Our detention warrants, we're averaging 20 a day. 20 a day, and that's just our police department. That doesn't include all the other municipalities that bring detention warrants to JPS. It is a community issue. It's not a JPS issue.
correct. And I'm
Right?
just asking.
What's
have
our
we-
piece?
Yeah, that's our piece. But because it's a community effort,
Yes, ma'am.
have we kind of said, okay, we're probably going to get that. So this is going to be the plan for JPS, and what are we going to ask the community to do? I would just like to see that overall plan for behavior health for Tarrant County. I mean, it's a little bit more than saying, let's just add a few more beds.
No.
Yeah.
I
mean,
don't
a few
think,
more
to
clinics.
that point, Dorothy, I would agree wholeheartedly. And I don't think we're actually at that very point.
Okay.
I don't think your interest is all of our interest, and that is, what is the overall plan for not only mental health, but what's the overall plan for what you do with we know we need a tower. To what extent, or you know you're going to need something different than the 11 stories that we have right now. What do you do with those 11 stories? And I think that's a continual basis as we go. I don't think anything we're doing right now would be anything you wouldn't do. What we need to figure out is what element of mental health, we put a mental health element in the Northeast. To what extent does that link up to the bigger picture, and what do we put in? And I think part of what's going to be dictated to us is when we get to the heat maps and we really dig down and figure out where those clinics should be. I think you look at that patient population there, and that's some of the services that you offer, which may be different than the Northeast, which may be different than what we offer at Watauga. And I think if that's where JPS really gets smart for the next 10 to 20 years in addressing the population needs to the services we offer in those clinics. And there always will be some level of a mental health component, but what is the subsection of it, such as, is there a stronger geriatric population that we need to address? But you're exactly right. The answer is, how does that overall picture place us? That's why I don't think at this point we're making any mistakes in what we determined to be the overall bigger picture.
I don't see that what we're doing as a mistake. I think that's your first initial start. But as we start that, I would think that you would already by looking, is it all going to be on this campus? Are we going to have any facilities throughout the community? I mean, that's the kind of conversation I know we should start having once you get this portion.
Yes, ma'am. I would not disagree at all.
And so kind of on that particular thing, there were some recommendations in the reporting about the school-based clinics. How is that being introduced within this entire plan?
We started having some discussions, both with Zelia, Joy Parker, Karen Duncan, as to what elements in a potential restructure of school-based clinics should we be offering. So we've done two things. We've begun to have some preliminary conversations with Cook Children's to see what role or how much, because you read through the report, you see a lot about community collaboration. So what should we be doing with Cook Children's in the role that they could or would be willing to play in school-based programs for us, since our PEDS program is not the strength of this organization, it's not our wheelhouse. The second thing it begs the question is, what can and should we be doing for adolescent psychiatry? And I don't think we're not at that, but I think you're at a point where we can begin to look at the restructure of school-based programs and figure out what goes in there. The other thing we've had a lot of discussion about, with Joy Parker taking the lead, is the aspects of telemedicine in school-based. We have a hard time right now sometimes because you literally have to go from the school to the clinic, which may not be far, but you have to have a parent and a guardian to do that. And so we have a few disconnects. So we've addressed that by beginning to open up initial talks with who wants to provide services, at what level do you want to provide services, and what should those services look like. Two things came out of that initial discussion. One, pediatrics, or the aspects of everything that we're doing right now, may not be our wheelhouse. Psychiatric need and concerns is definitely a JPS wheelhouse, so should we look to that? And is Cook or any other organization willing to partner or work with us in the services that we would provide?
What is the school, I mean, you're in the school, are they addressing any of their behavior needs? Because they're talking at some of their meetings about behavior issues that they're having in the school. So is the school a part of that conversation? Because we are there, if we're doing telemedicine, we're gonna have, that might be someone we need to talk to, because they are having some major behavior
They are.
issues
They're
in
not only
those
having
schools.
major behavioral problems,
district.
they're major challenges for our schools, as we know, just seeing it from what shows up at our clinics in the school-based structure. We would definitely work with the schools and work with what role a school nurse should play in their existing structure that they have, and figure out the best ways to do that. So that would be a part. But the great luxury there is we already have a structure. It's amending the structure or continuing with status quo with new support. But we have that structure, and we've taken that seriously from the report. Chuck, you had a question?
Just transport question. So from the current emergency room, be using what, the long tunnel to get over to a new psychiatric facility?
I don't know that we've actually would use the tunnel for transport.
We do in emergencies. If
Yeah,
there's-
I know we do
there's a major
now.
emergency,
I know we do now.
What would be the plan, though, with a psychiatric?
Zia, you might want to hit the mic and talk about that, from having a person come from one place to the other.
Transport has been.
Sure.
Yep, big deal.
Big deal.
I'm fine, I've been sitting. So are you asking about, like, if it's built over by TSP, about transport?
Yes.
No, well, yes, but
Okay.
the plan would be, currently is, we have patients come in our current
ER.
emergency room that on arrival there are deemed in one form or another to require hospitalization. That means transport from our current ER to the new facility, wherever it is over there.
Correct.
Just ask, would be using the long tunnel, and if not, what would you use?
It would have to be police or medical escort, but I will say that with new processes that we've been putting into place in the medical ER now, we are staffing an RN and a behavioral tech in there now, as well as the middle of September, we will start having a psychiatric nurse practitioner, as well as 2 licensed counselors 24/7. And so we're going to be able to do some very thorough evaluations right there in the medical ER. And so the ones that do meet criteria for admission, those individuals would be transported via the tunnel or via police to Trinity Springs. But we get a lot of patients right now. And prior to the front part of the PEC being closed, when the elevators were shut down, now that volume's going to the medical ER, as Bill said, and that's about 1,000 patients a month. And so those patients would start coming back to the PEC once we, if you all approve, have the new PEC built. And instead of the police having to go through the medical ER to come up to the PEC, they can now, they'll be able to directly go to the PEC as well, the new one.
And let me emphasize that again. The police have learned over years, but this is not a conducive environment to know you go to the 10th floor. If you have a psychiatric emergency room on the first floor in a prevalent spot that you can get in and out of quickly, that conditioning is going to change really quickly, and I think you're going to have less that just go immediately to the emergency room, voluntary or involuntarily, and they'll go to that center. Just like when we opened up the urgent care facility over here, for the first couple of months, everybody, I didn't know we had one, and then all of a sudden, that bifurcation started happening just on its own. So I think, Chuck, you'll actually see a much greater ability to get people in the right spot for a variety of reasons, just in its location on the first floor.
And we also have a patient family advisory committee over at TSP, and the families would be extremely excited to have it located by TSP at the ground floor, because right now when they're bringing their loved ones in, they're parking in one of the parking decks and they're trying to navigate the entire hospital to get to the 10th floor with their loved one who is going through a difficult time, and at times that can be very challenging for the family member to even get them to the PEC. So this does afford them an easy entrance in the new proposal as well.
Thank you, and you did that all standing up. Appreciate it.
Yes, sir.
Yeah.
Roger.
So, I'm sorry, Dr. these 4 items in the order, they seem fine to me, and that's about $200 million, you said.
200 million.
So, what's the time frame? Because these things can be going simultaneously, these 4 different projects, that's not a big deal. But when you start talking about the inpatient psych and the hospital bed tower, do we begin design? I know that there's going to be future changes in medicine and we want to be on the cutting edge. Sure. But I think there's also something to be said about the overall economy and us being able to strike while the iron's hot, so to speak. Not when it's at a boom like it is now, but when it's at kind of a bust. And I'm in construction, and I hate to jinx it. It's like saying 7 at the craps table, but we might have the opportunity to save a chunk of money, and I don't want to go through and 4 years later we have no ideas or no design on what the future is going to be, because then we're 2 years of design and we may not hit the wave right.
I think that's a great point, Roger, and that's come up, in a lot of different discussions, in a lot of different realms, and I hope that, where planning wants to encourage is that everything about this bond committee now becomes a concurrent process. I don't think any of us have the intention of setting aside, the bed tower for 10 years. I think we all have to be conscious of what the financial limitations are, but at the same time, to your point, the last thing we want to do is having looked back and said, we should have done this at X, Y timeframe. So hopefully our process will be all about now concurrent activity. And I think as we get into the psych tower and the bed tower, there's going to be a lot more discussions among us in terms of exactly how that gets delivered. There's huge financial issues, but there's also gigantic implications of transportation and access in this facility for the current structures. So I hope that, the effort, Robert, is going to be, we look at everything now concurrently. We have to pick the low-hanging fruit and get started, because the community needs us to get started on some critical issues, but I don't think anybody plans on letting any grass grow under their feet.
Not only will there not be grass grow, but the important aspect, and you'll see that when you get the budget, because we're going through that process right now, you'll see some initiatives as we as staff are trying to bring additional money into JPS in a proper way that doesn't create community upheaval and can do things. I think the other part of that too, Roger, is to what extent, and I mentioned it earlier with Cook, to what extent are our colleagues interested in collaborating with us? For example, and I use Cook because I don't think they would mind me saying this, but I'm going to say it anyway, so it's too late. But if Cook is looking at heat maps and Cook is thinking, you know what, we should put a clinic here and here, why would we not potentially, if it fits our heat map, partner with them? And you have a JPS Cook Clinic where you get wellness at a 360 level. And then why don't we look at the possibility of partnering with THR in certain capacities? So we as staff and Sharon and her finance team are going to present to you more in the budget from an initiative standpoint, but I think we got to look at that even greater. And as I mentioned before, I may make you all as a board feel slightly uncomfortable. It's not my goal, but it is my goal to take property that we have and utilize it far greater than what we utilize it for now, in the hopes of a revenue stream off the property that we have where we park cars on. So answering your question, we don't want to wait 6 years, and we want to hit the bubble of where we are, but at the same time, a major force in that is what can we afford in a debt? And what can we be able to pay so that we don't come back to y'all in a year and say, we got a bond we can't get out of, so the only thing we can cut is services. And I don't want to be in that situation. So we want to be smart in how we do it.
Good question.
I have one comment for you. You mentioned additional revenue stream. As part and parcel of this, I think you ought to look at where will a claim have an additional revenue stream
Sure.
as well.
Yeah. And that's a good point, and we are looking at a claim, and we are looking at what role can a claim play, and what role is there a community need for JPS to play a portion of that where we have historically not. And again, being sensitive to community upheaval, but at the same time, realizing that the community in a new era needs to look at JPS in a new direction too, because we're going to be doing things in a different manner, in a different way, because that keeps our mission strong. And our mission strong means we have a stronger service line, which directly impacts our colleagues. And we want to make sure that we're always there for them and for our patients. Great question.
It can be either expansion of services, or it can be managing the population that we have, and we can save a lot from the post-acute care overall.
What you will see, DT, to not take any of Sharon's thunder away, but what you'll see in the budget this time is an initiative to look, to stop the discussion and put into place plans to deal with our connection population and how you manage that population like any other insurance company would, even though we're not an insurance company. We've got 32,000 people. We know who they are. We know how they utilize our system. What are we doing about it? So you'll see some of those initiatives, as you'll see in some of our revenue stream and what we've done in revenue enhancement, just the preliminaries in this budget. And that really goes to Roger's question as to how quickly and fast we can move.
Robert, I guess several concerns I have or questions. One is that I think we also need to consider that there's going to be some redistricting, new districts, council, commissioner districts, or changes in that in the next year or two. Okay. Then we talk about where we see the biggest need for clinics. Okay. Also, I think we need to consider that how we sold the bond program. And I'm sitting here thinking, wow, because did we all in our particular areas in the community sell it new bed tower? Did we sell it? We're gonna have clinics, you know. So now, what do we do if we now reestablish what our priorities are? You know, we see that we want to do clinics now before we do the bed tower. Then it appears that we may need to go back and do some kind of marketing to the community based on here's what we see we're going to do at this immediate juncture. Because I say to you, in parts of the community, they're looking at a bed tower. Okay? The parts of the community said we need site facilities. So what do we do? But as we look at how the city is growing and expanding, I'm not so sure that we need to put new clinics just because the city, county is growing. It might be areas where we might have to put another neighborhood facility, community facility, health facility, then expand to the new areas. I mean, just based on qualified need. in those areas. And so, but if we're going to develop a new priority list, or if we ever had a priority list, I think that needs to come out of the board quickly, is that based on what we talk about around this table, here's what we see now where our priority list is for construction, and then go back and re-educate the community on this is where we're going to go.
Yeah, I think it's a good point, Ralph. One of the conditions, and Steve, you support me on this, argue with me on this, you were there just like I was. The Blue Ribbon Committee didn't say, let's create a 1, 2, 3 priority list.
Right.
They said, these are the critical needs, and then they expanded on those needs. The good thing is that regardless of what messages were sent throughout the community, when it comes back to the basis on which that bond campaign was structured, every one of these were considered high priorities by Blue Ribbon. And so there very well may be expectations relative to bed tower. I don't think it's fair to categorize it as a reprioritization, because I think it's consistent with the original list that was put out there. Now, if we were coming up here with something that was a brand-new idea that wasn't even discussed, then I think that would probably be a problem for us. But, I mean, Steve, your recollection of Blue Ribbon, how do you respond to that?
I think what you've put forth so far echoes the priority list of Blue Ribbon, and I specifically remember we didn't put it in a particular priority, this has to be done first, second, or third. It was, as a group, what was the most critical services that need to be added, and I think you've actually hit them all, or the vast majority of them.
One of just to supplement that thought, there was a great deal of discussion. If you go back and look at these reports from Boca Pal all the way to Cummins and Blue Ribbon, there was a huge amount of discussion related to strategies that JPS should begin to deploy to manage population health in a way that reduces the demand of inpatient facilities. And that's just got to be a continued effort for us. And one of the things I know that Robert and the staff have worked on when it comes to budget this year and subsequently is going to be strategies related to what is the culture of healthcare, back to Dorothy's point, what is the culture of healthcare doing? Which direction is it heading? And to the extent that we potentially have some ways to deploy new techniques, new programs that ultimately would reduce that bed tower demand, then that speaks to us on two levels. First, we meet the community need at a certainly more efficient level, but it keeps us in a much better position when it comes to putting operating cost next to capital cost. And so I think it's a great point, and I think we're gonna all have to continually look at how we market these ideas in the community and continue to, push these strategies forward. And again, I think every community, you're right, had different thoughts about maybe what's most important to them.
I do think, Pastor, that you have the ability, as we do, I don't think any of our initial recommendations are out of line. I think you could go back to a community and know that there is a mental health component to every one of our clinics. To know that one of our most immediate needs right now is the safety of that psychiatric emergency room on the 10th floor, and be able to address that. And then outreach to the community. The other challenge that we had, if you look at the needs, which are great, that those who wanted a patient tower to be first is more challenging simply from the standpoint of the larger cost of it, as we, to Roger's question or point, to look at those collaborative efforts and look at what we can do to potentially either bring that down or figure out additional revenue streams for JPS. So I'm not suggesting at all. I think you're exactly right. We have to educate the community. We have to tell them why we're doing it, what we did, and how it falls in line with a lot of the comments we've already made. So I don't disagree with you one bit.
Staff here at JPS and our outlying clinics are in the trenches every day.
Yes, sir.
But also, they're involved in all the new movements and the trends in healthcare.
Yes, sir.
And I really feel comfortable, and I think it would only be fair that we allow the staff to come with some recommendations.
You bet. Right.
And then we talk about that. Because one of the things that we have to be careful of, all of us have our little pet projects. And we want to be careful that we don't push for our pet project and we miss the key components of what we want to deliver healthcare.
Did all of you staff hear that what Pastor just said? We can't look at our pet projects? I'm just saying. Thank you. Well, it applies universally. It applies universally. Thank you, Pastor.
Zim, you had a question?
It's more a comment, I think, than a question. I'm not smart enough, I think, at this point to ask any substantive questions. But when we use the term low-hanging fruit, I assume we're talking about those imminent priorities that we need to take care of now.
Yes, sir.
We really haven't, as I can see it, we really haven't set up a series of priorities with timetables that go with them. They're all priorities to us right now. And so what this board has got to do now is start to put timelines and budget to go with that. And we need to be looking at what we need to be doing now, and we need to be what we're going to look at next. You had phase 1, phase 2, phase 3, they all look the same to me.
Yes, sir.
They all had towers in them, they all had this and that. As the Reverend points out, none of us know where healthcare is going in the future. You can paint any one of a number of pictures, and some of them aren't that good. So when you look at the investment that we would be making in the tower, it's in our best interest to make sure that we've kind of gone down a road a ways before we start jumping into that. I'm always amazed when we build roads. It takes about 10 years to get a road built, and by the time it's open, it's out of date and it's under capacity again, and so we have to start all over again. So I think that's one of the challenges we're going to have here, because a road is one thing, a tower is something else. So I think we really need to look at that and make sure we've got that figured out as to what it's supposed to do and how it's supposed to do it, how many floors it is, how many beds it is, all that kind of stuff. So I have no problem with delaying that, if you will, to get some of these more imminent priorities that I think what Trent is saying when he says low hanging, they're easy to go do, and we need them right now. So that's my comment.
Appreciate the comment.
And I think it's, Bill, Angie, I mean, tell me how y'all want to do this, but you've done some discussion already about schedule and what, yeah. Can you walk us through from these specific projects, what you see as timing options for us?
Let me give you as much detail as I know, and if you have further questions, people in my right can answer those. But you laid it out last month, Trent, at the board meeting. You know, from a timing perspective, these two clinics, if that was something that this board chose to approve, we could start those in February of next year. We know what that design basically looks like. We've got the architectural documents to bid that project. The completion of that is probably less than 2 years. If you look at the patient care center, which is relocating all of the clinics here and bringing the procedure rooms and the ORs from Arlington on this campus, that's probably a 3-year project, more than likely. With the schedule that Lou and Angie have laid out, that would be 3 years if we started, in the next few months. The psychiatric emergency center, with a fast-track process of that could be completed within 18 to 20 months. We feel confident with that. We basically have an understanding of what the design looks like, should look like. It's kind of an open concept. It would not take that long at all.
DT?
As we look at the planning, I know there's a lot of work that was done with the blue ribbon and everything else, and I think they do a very, very good job there. But I can't help but, suggest a little bit that we might want to take a look at, because of the changing in healthcare population and technology and all that stuff, to reach out rather than pull people in. We might want to take a look at shortly, spend some time with the micro hospital to see if it's appropriate for our model, rather than just big, population health center and all that stuff. Because I think we may have to reach out to, because of traffic and all that stuff in the next 10, 20 years. And we can do that for urgent care to relieve some of the high burden
Yes,
from the central location, but high cost to a more suburban area type thing also as well, so.
I agree. Good point.
Yeah, wow, that kind of gets on where I was thinking, when we look at setting priorities, and that's one of the reasons I was pushing, suggesting that we hear really in detail from staff on where you see our next moves would be. Because I was asking myself, one of the things is we have the Mercedes-Benz out at Northeast now, clinic.
It's okay, Roger.
Oh, sorry, Roger.
So far, this
It's been going great.
Roger and I have thick skin, we have thick skin.
But what things at the Northeast facility we didn't do? Or that we could move from here there if we had done some things different, okay? So that says if we look at those new clinics, then that maybe then takes the load off of the main campus, or we could transfer services. So I would hope we somewhat look at that. So what DT, the micro, that could, relieve some of the workload, or we could maybe add some things in here as we go forward.
Yes, sir.
Now, one other question. If we went to single bedrooms now, how much would that reduce? How many beds rooms would we reduce?
Would you lose?
If we went to
Went to private rooms, how many rooms would we take away
from the existing
from the
facility?
existing facility? Yeah, how many beds would we take away?
Over half our beds are semi-private.
Yeah.
On this side of the
On
street.
this side of the street.
Everything over there is private.
So what, a swag, 200 beds? Yes, sir.
Yeah, wow.
It is a lot, no question. Yep, that is a challenge for us.
And that was also one of the big reasons we put that tower there, because we talked about nobody wanted to go to a hotel and stay in the room with someone else. And we still know that you can't use them as two beds sometime, depending on what disease the patient have. So I think that as we move on these priorities, we still need to be looking at what your towers, because it's,
No doubt.
I don't want any more, we're gonna have some of the, what's the red, what you send out the notices on now, when you are backed up in the ER?
Oh, the boarding. Yes, ma'am.
Yeah, the orange something, orange.
Oh, code yellow.
Code yellow.
Sorry.
Don't forget, those code yellows.
Don't be asking me color questions, but go ahead.
Okay.
Yeah, no, I totally agree. Y'all are not saying anything we haven't said in our in-depth meetings as well.
Okay.
We do need a short executive session. Some of this discussion relates to things that are executive session qualified, so I'm not rushing it, but if you're willing to go into that now, we can. If you've got more questions for the staff, we'd happy to entertain those too.
Everybody good?
Everybody good. I
All right,
won't
very
throw
good.
my
Well,
other
then it is
hat out there.
4:35. We're going to adjourn to a brief executive session. We'll come back as soon as we're finished. Probably 30 minutes.
But I-
Planning Committee and Board is returning from our executive session at 5:21 PM. Having no other items on the agenda, we would entertain a recommendation based on the meeting today. And motion?
Mr. Chairman, I move that we recommend to the Commissioners Court that JPS move forward of design and of 2 community clinics and the psych emergency facility, the patient care center, and a parking garage.
Any question or discussion on the motion?
I would second that motion, Mr. Chair.
Second from Mr. Powell. Any question or discussion? Not all in favor, say aye.
Aye.
All opposed, same sign. Motion carries. Thank you all very much.
Thank
That
you.
concludes our agenda. Thanks for
We
your
as staff,
patience.
thank you all very, very much.